So, thank you for inviting me to this meeting. I must first of all clarify that I'm here as a doctor, a clinician, and a researcher. And obviously, whatever I say is not to be taken as any investment advice or even financial educational advice, because I am a medical doctor here, trying to give you a clinical perspective of the GLP-1 landscape and what the future holds for us. I work at the Chalaram Hospital in Pune, and we are a hospital dedicated to diabetes care, uh, uh, care of diabetes and all its complications, and also associated conditions like obesity. Next slide, please. So I'll be talking about what the future holds for us from a very clinical perspective. May I have the next slide? So let's look at what is GLP-1. So GLP-1 is called glucagon-like peptide. Now, supposing you're going to have your lunch, and let's assume that you're going to have some rice for lunch. That rice has to be broken down into glucose, and the glucose works on your cells in the gut, and the gut produces this hormone called GLP-1, and GLP-1 is will release insulin, and the glucose which was there in the rice and now reaches the blood will be brought down by the insulin which is released thanks to the GLP-1. So when you eat rice or bread or roti or anything sugar, what will happen is that sugar will stimulate your cells in the gut. They'll make GLP-1. GLP-1 will tell the pancreas gland to release insulin when the sugar is high. And once insulin is released, the glucose in the blood is used up by the cells and the glucose level comes down. So that's the first action of GLP-1. But it also turns out that GLP-1 has an action beyond glucose control. Initially, GLP-1 related drugs were used for diabetes, but then they found that these drugs were causing weight loss because they tell the brain to stop eating. So that's another effect of GLP-1. People have also looked at GLP-1, which to bring down the glucose levels, it also talks to the liver. And in type 2 diabetes, the GLP-1 signal is either weak or blunted, and GLP-1 drugs restore it. So GLP-1 is like an intelligent software for the pancreas. When the sugar is high, it releases insulin to control the glucose levels. But the important thing to remember is that it also acts on the brain to suppress appetite, and that's the main reason for their weight loss and use in obesity. Next slide, please. So this is the way it works. As I mentioned, it acts on the pancreas for sugar control. It acts on the brain. Some people call it the hunger hormone. It stops hunger, and it acts on the brain and reduces hunger. The third action is more interesting because via its effects on glucose, via its effect on suppressing appetite, via its effect on weight loss, studies have now shown that it can have a protective effect on the heart. It can cut down the risk of heart attacks and strokes in people with high risk diabetes, and also newer studies show that it can also similarly cut down the risk of cardiovascular events even in people without diabetes who have obesity. Next slide. So that talks, now we talk about the effect on diabetes, because initially these drugs were discovered as anti-diabetes drugs. The GLP-1 drugs are not new. They have been here for almost 2 decades now, 15, 18 years. But what is new is the newer forms of GLP-1s, which have got a strong effect on weight loss, such as semaglutide and tirzepatide. So how does this drug stack up against the existing drugs? I'm not talking about diet and exercise, but I believe diet and exercise is fundamental. But what you will see in this column is on your left, you will see all the drugs. Second, from the left, you will see the glucose reduction, the HbA1c reduction. Now, the HbA1c is a simple blood test that tells you the 3-month average glucose levels. In people with diabetes, generally, we keep it below 7%, but below 6.5% is ideal. You will see that among all the drugs, insulin is a drug with a major HbA1c reduction. But insulin has two problems. Insulin causes weight gain. Second, too much of insulin can push the blood glucose levels below normal. And that is why the GLP-1 agonist and the GLP-1 GIP that works against two hormones, these drugs also have very good A1C lowering. They do not produce weight gain. In fact, they cause weight loss, and they don't produce very low blood glucose levels below normal, hypoglycemia, which can be dangerous. So this is the advantage these drugs have over insulin. And on your extreme right, you'll see the cardiovascular benefit. Sorry, go back. On your extreme right, you'll see the cardiovascular benefit, and you'll see that both the GLP-1 RA, that is semaglutide injectable, and the GLP-GIP, which is tirzepatide, both have probable cardiovascular benefits, which are more or less accepted worldwide. Next slide. So now let's look at injectable versus oral. Oral semaglutide has been available for many years now. So on your left, you'll see the injectable, and then on your right, you'll see the oral. You'll immediately see that injectable causes better A1C reduction of up to 2.5%, and the oral causes less A1C reduction of 1.4%. You'll also see that the weight comes down by 10 to 22% in injectable and 4 to 8% by oral. There's a small mistake in the oral GLP-1 slide. The oral GLP-1 is semaglutide. Oral liraglutide and oral tirzepatide are not available. Instead, a drug called orforglipron is going to come. So oral liraglutide and oral tirzepatide are just hypothetical and they're not really available. So now I want to talk about the problems with injectable. The only problem with injectable is the injection barrier, the cold chain. It has to be transported at a particular temperature, and a high cost. The oral one, the limitation is a limited bioavailability. Whatever is eaten is not absorbed properly. Also, the oral drug, the oral semaglutide, has to be taken on empty stomach with half a glass of water, half an hour before the first sip of tea. So it's very rigid dosing, and therefore it is somewhat less effective than the injectable. But there is a molecule from Eli Lilly called orforglipron, and that probably may not have such limitations. Next slide, please. So that brings us to the Indian patient and Indian diabetes crisis. So as mentioned, there are 101 million people with diabetes in India, 136 million with pre-diabetes, 50% are undiagnosed, and among those who are diagnosed, 50% are uncontrolled. Right now, the GLP-1 monthly costs are very, very high, and affordability is a primary barrier. The liraglutide, which is injected daily, is available at about 3,500, and the weekly injectables are available starting from 8,800, and depending on the molecule can go up to over 20,000 rupees a month. So it's very expensive. And many Indians are, as mentioned earlier, are thin but have abdominal obesity, which drives diabetes. Abdominal obesity makes the body resistant to insulin and drives diabetes. The urban middle class segment is a good proportion of people are not able to afford it now and will afford it. And we hope that generics will come into the Indian market, and that will improve the accessibility to care and also bring down the cost. So the penetration across India will be there, and the cost also will come down. That will be very good for patients. Next slide. May I have the next slide? Okay, now we look at the obesity landscape. There are around 254 million people with obesity in India. 44% are overweight also. And of course, 5% have diabetes. Five-fold higher diabetes risk is there in obese people. When compared to people who are not obese, people with obesity have 5 times higher risk of diabetes. Obesity is now, earlier, obesity was not considered to be a disease. People were thought to be healthy. But today, the WHO itself has classified obesity as a chronic, which means it's a long-term disease. It's also a relapsing disease. if diet and exercise control it, it bounces back. So obesity is a condition characterized by excess weight that impairs health and, if not treated, can lead to complications such as type 2 diabetes, which is a common form of diabetes, hypertension, sleep apnea, NAFL. The new name for NAFL is MASLD, uh, which was earlier called fatty liver disease, arthritis. So many diseases are associated with obesity, and only 3% of obese people worldwide get pharmacological therapy. There was diet and exercise, then there was bariatric surgery. There was nothing in between for us to tell patients. Now, since 1 year, we have injection tirzepatide uh, and injection semaglutide. Next slide, please. So, what does the next 5 years foretell? So we saw in 2025, we saw that Eli Lilly launched Mounjaro, which is tirzepatide, and Novo Nordisk launched Wegovy or Ozempic, which is semaglutide. Wegovy and Ozempic are two brand names of semaglutide. Wegovy is for weight management because the dose goes up to 2.4. Ozempic is for type 2 diabetes management. In general, the dose goes up to 1, but in the US, even up to 2 mg is approved for treating type 2 diabetes. So obese people with a body mass index which is high uh, can receive treatment with these drugs if they're not responded to diet exercise. Well, in 2026, as we speak today, we have the Indian generic semaglutide injections, which are weekly injections coming. In 2027, we expect that newer molecules will come, single molecules which will target multiple receptors. In 2028, we may get another oral pill, and these molecules are being studied for uh, NASH, which is earlier called fatty liver disease. A new name for NASH is MASH, metabolic dysfunction associated steatohepatitis, sleep apnea. Uh, there are interesting studies, important studies looking at the effect of these drugs on dementia because they act on the brain to suppress appetite, and some interesting data is there that they may improve dementia, but it's not approved and we don't have trials yet which are positive. And finally, in 2030, we may get data on GLP1 for addiction, for kidney disease and heart failure. There is already a kidney disease trial available for injection semaglutide in type 2 diabetes called the FLOW trial, where it protected the kidney. Now, these drugs suppress appetite, and by suppressing appetite, they take away the joy of eating. Similarly, like reducing food craving, they reduce the craving for alcohol, they reduce the craving for smoking. So they have been tested in addictive disorders, and many such cases are being reported by doctors. I want to add that these drugs are not without side effects. They have good effects, but they have lots of side effects. They can not just cause good sugar control and weight loss, but they also cause a lot of gastrointestinal side effects, especially at the time of starting the dose and increasing the dose each time, because you have to keep on increasing the dose till the target weight loss and or sugar benefit or whatever is achieved. They are also they have they are contraindicated. They should not be used. Contraindicated is a more medical term. So it should not be used in people with severe depression, especially with suicidal ideation. The suicidal ideation tag was supposedly removed by the US FDA, but the depression tag continues to be there, and we should not use it. Doctors should not use it in severe depression. People with a family history or with a history of a rare thyroid cancer called medullary thyroid cancer should not take it. These also carry a risk of pancreatitis because they stimulate the pancreas gland, which makes insulin. They also may cause some damage to the pancreas called pancreatitis. They also very recently and over the last year, they have been shown to cause a very rare condition of the eye uh, where it can affect vision. And also, in people with diabetes, they can worsen diabetes-related eye retinal disease. Retina is a screen behind your eye with which you see the world, including this screen in front of you is seen by the screen on your eye. And that retina is directly can be affected by these drugs if sugar control is very rapid. And this retina can be directly seen by the ophthalmologist. In fact, every diabetes patient should have a retinal checkup annually, even otherwise. And this, if it's very severe, we should not use this drug. And finally, these drugs can weight loss doesn't mean everything, because weight loss can be fat loss and fat-free mass loss. What is fat-free mass? Fat-free mass means muscles, bones. So for every 4 kilos of fat loss or weight loss, 1 kilo may be lean body mass or muscle. So they can cause muscle loss, which means people may become frail. So people may have to do strength training and improve protein intake. I thought it's important to give a perspective that these drugs have to be used judiciously under medical supervision, because they have effects and good effects and lots of side effects, and should be taken under medical supervision. Uh, Next slide, please. But it's all very exciting because GLP-1 is a very powerful drug. It acts on the sugar, weight, and heart. India is the world's diabetes capital, and we could not do much about weight other than diet, exercise, and bariatric surgery. But now we have another tool to help patients. And the affordability generics will really help improve access and cost. Diabetes is a chronic condition, so good uh, uh, brands could emerge which will help patients. Obesity was not really treated, but now GLP-1 will change that. And beyond diabetes and obesity, it may have a protective effect on the heart, the liver, on addiction. And therefore, people are saying that it could be a big boon. But at the same time, I would be a little cautious, because, yes, there is some chance at helping a lot of patients, but also there is a chance of misuse and side effects. And therefore, we will have to be we will have to wait and watch how the GLP-1 story proceeds. Thank you. Next slide, please. Thank you for listening to me. It's a pleasure talking to you. And the organizers told me that I can take questions straight after my talk. So I'm happy to take any questions right now.
Thank you so much, Doctor. It was a wonderful, detailed explanation. And I will let other people ask some questions on this. I will let first Nikhil ask a question. He wants to ask some questions. Allow your mic, Mr. Nikhil.
Hi, am I audible?
Also,
Yes.
before
Yeah,
Nikhil, if you go, I just wanted to keep keep the questions brief because Doctor may
yeah,
be
yeah,
running out
sure,
of time.
definitely.
Yeah.
Yeah, thank you, Dr. Unnikrishnan, for this detailed insights that you shared on a weekend. Sir, I had just one question. We discussed about this GLP, where we have seen a lot of generic companies now come up. Natco yesterday launched probably vials at some 1,300 rupees. So I just wanted to understand how will in your clinical experience, what is the dosage accuracy difference that you see between a pen-based dosage versus a vial-based dosage? And do you think that vials can probably take over the semaglutide prescriptions vis-a-vis the pen? Like, just trying to get your perspective. What do you
Thank
think
you.
of? Yeah,
Well, if just to give you an example, initially when tirzepatide, which is Monjaro, was launched in India, Eli Lilly launched it with vials. And then the uptake by July first week, they launched pens. So first March, April, May, June, they were vials. And what we found is that vials were acceptable to patients just like pens, because at that time there was no competition. But today, with a large number of different devices coming, I think vials will be only for people who have an affordability issue. Because from what I hear, the price is really going to come down. So vials will be only for people with an affordability issue. Most people would like to take pens. There may be single dose pens, there may be multi dose pens, but pens are more convenient because it's easy to carry around when they are traveling, or if they've forgotten to take it, they'll have to take it out, put it in the fridge, take it out, take it in a syringe. So I think vials, pens will be the vast majority of patients, but vials will really improve access to the really poor who need it.
yeah, this is helpful. So thank you so much. I'll come back in the queue.
Yeah. Prashant is asking that does this injection need any regular blood tests or monitoring?
Yes. So, for example, in our institution, we have a pre-GLP-1 assessment testing. People come in fasting for the test. They do their height, weight, their blood glucose levels, their cholesterol, their blood pressure, their ECG, but they also do two, three additional tests. The first test they do is, of course, their kidney function. But the first additional test they do is we insist on an eye checkup because it's important to do an eye test before starting this because if there are some risk factors for eye disease that gets picked up. The second thing we do is we do their body composition because sometimes when people rapidly lose weight, they may lose muscle and that may make them frail. So we do their body composition. So these two tests are done. And we also, whenever we start the GLP-1, our team trains them. And also, we also insist on many people who say they have to do strength training and increase protein intake. So they meet a dietitian and the strength training, resistance training. For that, we arrange a small demonstration at their lifestyle at our lifestyle center because people ask, डॉक्टर मसल लॉस प्रिवेंट करने के लिए क्या कर सकते हैं तो आई यूजुअली टेल देम दैट you can do two things. You can do strength training and protein intake. Now, strength training is more important than protein intake because that strength training will prevent. So these things have to be done, and that's when you get the maximum benefit.
Yeah, super. Also, RK is asking that are vials and pens interchangeable? Like, can vial patient use pens for sometimes, like if they go on a trip?
Absolutely. So
Yeah.
what happens is very interestingly, these drugs cause gastrointestinal side effects. So some of my patients who are working, say in the IT sector, they will take it on a Friday and then they will take it because they get the gastrointestinal side effect on Saturday, Sunday, Monday they can go to work. But people who are say going from Pune to say Goa, for example, they will take it on a Monday because they don't want to get the gastrointestinal side effect during their holiday. And so they usually take the wire pens with them when they travel and vials at other times. But today we don't have vials because Eli Lilly only launched vials for the first few months, and now it's all pens. I suspect pens will be the main way doctors use it because uh, pens are also affordable today to the majority of people, and people uh, who need these injections also need regular monitoring. So that pen will be the main group who can afford both the care and the monitoring and everything else.
Yeah, perfect. Also, Prashant is asking one more question. Do patients need to take these medicines lifelong or can be, discontinued after a certain clinical goal is achieved?
So across the world, studies have shown that people don't take this GLP-1 long. People who take it for obesity tend to stop it after 6 months, 1 year, and that's a huge challenge for clinical doctors. So studies have shown, now if you want to know the science, studies have shown that if you give it, there's a Surmount 4 trial done on tirzepatide, and there is another trial for semaglutide. What they did in these trials is they gave these drugs for say a year or 1.5 years. Then after they took it for a period of time, they stopped it in one group and other group continued to take it. The group which stopped it after 1 year, let's say they lost about 15 to 20% of the weight. Once they stopped it, within 6 months to 1 year, half the weight jumped back. In other words, if they stop the drug, on an average, half the weight will come back in a year's time. But many people are able to manage with diet and exercise. But people who take it for diabetes are unlikely to stop it. The reason is because there is a very tangible health outcome on the blood glucose level. And if they stop it, the weight comes back, the sugar comes back. But for weight, the people who take it world over, they have shown that people tend to stop it. And I think that's not correct because when you start it, you should start it for a long period of time. And if you stop it, patients should follow diet, exercise, and if the weight comes back, they may need to start it. And that's been a challenge with GLP-1. You identified that problem with many people stopping it, and there's an opportunity for some education and awareness of the public there.
So it's not just the drug. We need to combine it with the exercise and diet as well. Perfect.
Absolutely. It is not diet exercise versus these injections. It is diet exercise plus these injections.
Understood. Perfect. Ashish wants to ask some question. If allowed your mic, Mr. Ashish, you can ask the question. Mr. Ashish? Uh, okay, I think so he's muted. There's a question from Mr. Uday. He's saying that was there a second order effect of GLP-1 on Indian, let's say after 10 years, if an Indian patient loses 10 kg on these drugs, but 4 kg of that is muscle, aren't we just making them thin but weak? Specifically, when they stop the drug and inevitably regain the weight, don't they regain it at 100% fat, leaving their metabolism permanently broken and worse off when they started?
Yes, you are absolutely right. Because if the patient taking this drug is not monitored, and if this patient loses a lot of muscle, this patient may lose weight, but they will look very thin and frail, and they may be prone to falls as well. So we are not helping that patient really. And very interestingly, once the weight is gained back, there is no guarantee that you're going to gain back muscle. Once you stop it, you may gain back more fat. And whatever muscle you've lost, if the patient is not exercising, they don't gain it. So if you see the new generation of drugs that is going to come next is combining this GLP-1 with agents that improve muscle development so that you can get fat selective weight loss. There is one particular molecule called bimagrumab, bimagrumab, which is when combined with GLP-1, GLP-1 will cause fat loss and bimagrumab will prevent the muscle loss. But for the moment, there is no such agent. So we'll have to tell the patient to follow strength training and also increase protein intake because we want our patients to get better health, not simply lose weight. And also, people taking it just to lose weight for cosmetic purpose has to be discouraged strongly because this is a medicine for health, not for just weight loss.
Perfect. Ashish can go next. If I allowed your mic, Mr. Ashish. Like he's asking from a long time. I guess his mic is not working properly. Uh, okay. Aditya is asking that given we don't have any long-term data on GLP-1 behavior in Indian population, both in terms of efficacy and side effects, how are doctors building confidence to prescribe them in the long term? There's no studies for the long term.
Well, I think any molecule that comes into the country or into the world usually has an initial very strong phase where doctors are very, very excited by their use. They see weight losing, patients are excited, everybody is happy. Then will come a sort of realization that yes, this drug has to be used selectively. It has got some side effects. Many people will lose muscle. And then there'll be a consolidation phase where this drug will be taken up. So I believe that yes, initially you will see some euphoria around this molecule, but eventually, the medical practice will go to the right patients and will help. And from day one, doctors will only use it for the right patient. But the people who are looking for weight loss will discontinue it on their own. Doctors are going to use it for the right patient, but patients may discontinue it. So this is the story. Initially, many people will come asking for it. Their BMI will be 35, 40, very obese. Doctors will write it because they need it, the patients need it, but then people may stop it, and then that's not a good thing. So I think in the long run, it will all be the long-term use of these drugs giving benefit to patients. So that initial increase in numbers may really come down over a period of time to some stable numbers. But I feel that this will continue to be used for years to come.
Perfect. I think so. We can take a last question from Nikhil today, and because sir has some other meeting to go after this. So, Nikhil, you can ask your last question. Keep it brief.
Yeah,
Yeah.
yeah, yeah. Just a
Thank you.
follow-up, sir. Probably the pharma companies who have filed the dossiers with pen, if they want to switch it to vial, will they need a fresh regulatory submission? Maybe a very naive question, but if you have an idea on that, that would be really
No,
helpful.
I don't have any idea on that. What is the regulatory? So apologies, that's one area I will
No
not be
worries,
able
no
to
worries.
help you.
Thank you so
Thank
much.
you.
No
Thank you,
worries.